So our topic of discussion here is going to be sudden infant death syndrome. We'll start with a vignette. We have a 3-month-old baby boy who's brought to the emergency department by EMS after his parents found him apneic and pulseless. CPR efforts were initiated in the field and continue during transport. Further resuscitative efforts in the ED are unsuccessful and he's pronounced dead. His parents report to have found him lifeless and blue this morning at 6 a.m. His mother became concerned when she woke up and realized that he had not woken up for his 4 a.m. feed. When she checked on him, she noticed that he was not breathing. When he did not respond to her picking him up and calling his name, she immediately called 911. The parents report that he sleeps in a crib alone without toys or large bedding. He has no medical history and his vaccines are up to date. Although he was born 6 weeks early, he spent only 1 week in the NICU and has been otherwise developing appropriately since discharge. Review of system is notable only for mild upper respiratory tract symptoms. Physical exam in the ED did not reveal any signs of trauma. Parents appear appropriately distraught. So this was a vignette that I found in the literature, and this is a rather classical case of SIDS, sudden infant death syndrome. More appropriately, you could call this sudden unexplained infant death, which is more of a broad characterization of all the different things that can cause sudden death in a child. It's really not a very useful classification because it encompasses so many diverse causes of death in infants. However, this appears to be sudden infant death syndrome. Why does it appear to be sudden infant death syndrome? There are some things that will cue you in that direction. Although, remember, sudden infant death syndrome it's a diagnosis of exclusion. So you do need to do a physical exam. You do need to do an autopsy, and we will do those things. But just by looking at this vignette, there are certain things that can cue you in the direction of SIDS. So first of all, this baby is 3 months old. The vast majority of cases, over 90% of cases of SIDS, occur between 1 and 6 months of age. This baby is right in the middle of that, and as a matter of fact, a majority of cases occur between 2 and 4 months of age. So very narrow period. And remember, you can get SIDS all the way up to 1 year of age. So this baby is right in that problem period. Secondly, this baby was premature. So prematurity is an independent risk factor for SIDS. Even though he is healthy and has been developing appropriately, he's still a premature baby. Premature babies are at higher risk for SIDS. Thirdly, he's a boy. Boys are at greater risk for girls. Not by much, but they are at greater risk. Other than that, this baby doesn't have any other risk factors. And there are a lot of risk factors for SIDS. Some are more riskier than others. But remember, in no patient are you ever going to have all of the risk factors. You're just very stereotypical case screaming you in the face. Okay, so some things that don't look like SIDS, but certainly don't point you away from it, would be the fact that baby sleeps in crib alone without toys or large bedding. That's a good thing. You shouldn't be sleeping in crib with anything other than really nothing, preferably, other than some clothes. And then vaccines are up to date. That's good. And baby's otherwise healthy. So all of that is good. But you will see babies with SIDS that there are things that are the way they should be. But this baby does have some pretty significant risk factors. Okay, so let's talk about that in greater detail. Sudden infant death syndrome is technically defined as the sudden unexplained death of a child under the age of 1 year where no other cause can be attributed to it. So because it's a diagnosis of exclusion, you really can't prove it. There's really no test that we have available that you can run a lab or run a CT or something like that. You can say, oh, yep, this is for sure sudden infant death syndrome. You don't have that. This is a diagnosis of exclusion. So what that means is that there are going to be other things that we consider to be somewhat common, okay, so like asphyxiation or child abuse, that you will want to rule out. And so you are going to get a skeletal survey, you're going to get a toxicology, you're going to do an autopsy. But other than that, if you don't have any other logical explanation for the death, then you will call it sudden infant death syndrome. So I think I mentioned this earlier, but sudden infant death syndrome falls under sort of an umbrella of what we call SUID, or sudden unexplained infant death. And that can include a lot of things. So that's like asphyxiation or choking, foreign body. That asphyxiation can be purposeful or accidental. It includes things like cardiac disease, arrhythmias that went under the radar, then more obvious things like electrocution or poisoning or trauma. Epidemiologically, in the United States, sudden infant death syndrome is the third leading cause of death in children less than 1 year of age. And that's an important fact to keep in mind. Sudden infant death syndrome can only be diagnosed in, surprise, infants. And so if the child's over 1 year of age, not sudden infant death syndrome. Even if the child is more than 6 months of age, you really should be thinking that this might be something else. Because this tends to happen only in children around that 1 to 6 month of age window. So if you actually take out that first month of life in that first year, if you take out the first month of life, and you're talking only about babies between 1 month and 1 year of age, then sudden infant death syndrome becomes the most common cause of death in infants outside the neonatal period in the US. 15,000 cases were reported worldwide in 2013, and that is down from when we really started understanding what some of the risk factors are for SIDS. We'll talk about that. Back in 1994, we found that babies sleeping in the prone position, meaning on their tummy, are at a much, much greater risk for developing SIDS than babies who sleep on their back. So what did we do? We told parents, put your babies on your back. We call it the Back to Sleep program. And this corresponded, the more parents were educated, this corresponded with a significant drop, actually about 50% drop in SIDS cases between the years 1994 and 2000. And then, like I said, there's a slight male predilection, but really that's not going to help you too much in diagnosis. Okay, we don't know the etiology, the exact mechanism is unknown, but what we do know are a bunch of risk factors. Some independent risk factors, some maybe not so independent. But there has been a study, these authors put out what's known as the triple risk model. And what this is these authors identified these risk factors, put them into 3 categories and said, I don't know if they did a meta-analysis or what, but they said that if there's one risk factor in each of these 3 categories, then the baby's risk for SIDS is much higher than if they were to have risk factors only in 1 or 2 of the categories. Okay, so here's these 3 categories: vulnerable infant, critical developmental period, and exogenous stressors. So vulnerable infant, what does that mean? That's kind of a vague term. Vulnerable infant just means pretty much non-modifiable risk factors. So genetic, developmental, or environmental factors which contribute to an infant's intrinsic risk factors. So some of these are very obviously non-modifiable: male sex, prematurity, Black or Native American race, particularly Alaskan Inuit, young maternal age, and then these other ones are sort of semi-modifiable risk factors. So low socioeconomic status, it's technically, it's theoretically modifiable, but family's poor. There's really nothing you can do about it. And then prenatal substance exposure and poor prenatal care. Now these are modifiable to the extent that before the baby's born, but once the baby is born, then it's a fait accompli. The baby either was or wasn't exposed to substances, or the baby either did or did not receive good care while in the womb. So you can see that these are really non-modifiable once the baby is born. So these are your really non-modifiable risk factors that contribute to what we know as the vulnerable infant. So for instance, a premature Alaskan Inuit baby boy born to a 17-year-old woman who lives in poverty and smoked during pregnancy. That would be classic, although rare, classic sudden infant death setup. Next is the critical developmental period. Now this is a theory, and what the theory here is that at a certain point in the child's development, the processes are become a little bit disordered normally, just for a short period of time. And that period of time is roughly between 1 to 6 months of age, perhaps even more so between 2 and 4 months of age. And the reason that the authors theorize this is because there's a long range of time when a baby can have sudden infant death syndrome, anywhere between 1 month of age, or birth, I guess, all the way up to 1 year of age. But why do all these cases occur between 1 and 6 months of age? You could have the same baby, or the same environment where maybe the baby is sleeping with the parent, or the baby is sleeping in the prone position, but that baby is still more likely going to develop the sudden infant death syndrome between this window of time, this 1 to 6 months. And so, what the authors gather from this is that perhaps there's some homeostatic mechanism that's just slightly disordered as a normal process of development during this period of time. And so when they're going through these months of age, they're more likely to have sudden infant death syndrome. It's a theory. We don't know if it's true or not. But what you can gather from this is that in the existence of these other two categories, when the baby is going through that 1 to 6 month of age transition, that is where you really need to keep an eye out for sudden infant death syndrome. Okay, and then lastly, the exogenous stressors. So really, this is what the authors call it, but you could also just call this modifiable risk factors. This is really the target of our education, our patient education, when we are instructing the parents on how to take care of baby when they take baby home. So first of all, unsafe sleeping environment. It is thought that overheating, warm room, is a risk factor for sudden infant death syndrome. Other things include, as far as sleeping environment, include is the baby going to sleep in an approved crib? So you go and buy cribs. There's the Consumer Safety and Protection Bureau, or whatever that bureaucratic organization is, that puts their stamp of approval on various items, and cribs is one of them. So you want to make sure that the crib is approved, quote unquote. And then you don't want to have pillows or blankets in the baby's crib too. So all of that contributes to a safe sleeping environment or an unsafe sleeping environment. Next, prone sleeping. This is the big one here. Okay, this is probably going to be the one that a test asks you. So back in 1994, we found out that babies who slept on their belly are at a much greater risk for sudden infant death syndrome, 5, 6, 7 times more likely. And so we got the bright idea that, well, let's start telling parents to put their babies on their back and see if that does anything. And in fact, it did. And from 1994, when we started this program called the Back to Sleep program, to 2000, the number of SIDS cases dropped by 50%. And so it is now absolutely recommended by the American Academy of Pediatrics that babies sleep on their backs. Bed sharing. This is another big one because of cultural practices. So in some cultures, it is common for parents to share a bed with baby. Now, you would think, well, what's the big deal in that? Plus, the parent is closer to the baby, so that sounds like it might be a good thing. If mom and dad are sharing a bed with baby, where do you think they're going to be sleeping? Are they going to be sleeping in the crib, or are they going to be sleeping in mom and dad's bed? They're going to be sleeping in mom and dad's bed. And mom and dad's bed is an unsafe sleeping environment. It's adult beds, children's beds, as opposed to cribs, are softer. There's pillows, there's blankets, plus you got mom and dad who might roll over the baby. And so this is really not a good thing at all. And I have read things just on like Yahoo News or Google News or CNN that say, oh, bed sharing is not that bad. No, bed sharing is a no-no, all right? And it's still a no-no, and it will be a no-no for a long time, I'm sure probably forever, because, I mean, until parents start sleeping in cribs, which I don't think is going to happen anytime soon, you're not supposed to do it, okay? And that risk goes up even more if the parent has been consuming alcohol or is on sedatives, where the parent might not wake up if something were to happen. And I believe the exact numbers are if it's one parent in the bed with the baby and it's bed sharing, the risk is 2.5 times higher. It's a 2.5 higher risk than if the baby were in the crib. And that risk goes up even more if there's two parents in the bed with baby or two people in the bed with baby. So it's actually 5 times the risk if there's two people in the bed with baby. So you can see that you don't want to have people sleeping right next to baby in the same bed. Okay, that's a bad thing. Now, on the other hand, that having been said, while you don't want a bed share, it actually reduces the risk of SIDS to have the baby in the same room as mom and dad. So while baby should not be in bed with mom and dad, it is a great idea to have baby in a crib in the same room as mom and dad. That should be encouraged. That actually reduces the risk of SIDS. And then finally, nicotine exposure. So note that I put nicotine exposure, not tobacco exposure. Certainly tobacco exposure is bad too, but nicotine exposure, that actually encompasses a little bit more. Here's two things that I want to point out with this. First of all, a study came out of Germany not very long ago, only about, 3 or 4 years ago, that says that there are some children that have a mutation or a reduction in the amount of an enzyme that is responsible for metabolizing nicotine. And it actually happened to be that those children were at higher risk of sudden infant death syndrome. Or, I guess in other words, probably the way they found out was that children with sudden infant death syndrome were more likely to have that mutation or that anomaly in that metabolism process. So what does this mean? It means that nicotine exposure will raise your risk of sudden infant death syndrome. And this is something that we already knew. We already knew that smoking around baby was bad. But it's not just smoking cigarettes. This is any kind of nicotine. And the reason I bring this up in particular is because mom and dad might smoke around the house, then they are expecting baby, and let's say dad was a smoker and dad's going to stop smoking now. And rather than stop smoking or smoking outside, he decides to get one of those new popular electronic cigarettes. And yes, those are good for adults because you're getting rid of the tar and the tobacco and everything that can be harmful and carcinogenic. However, nicotine is still going to be released when the smoker exhales. And that amount of nicotine presents a risk for the child. So it's actually nicotine exposure. It's not just the smoke, it's the nicotine too. All right, and then there's an increased incidence in winter months. We don't know if the winter months are an independent risk factor or if it just means that in the winter, parents tend to put more clothes on their baby, and we know that having more clothes on is a risk for asphyxiation and stuff like that. So there's an increased incidence in winter months, but we don't know if that's directly causative or not. And then risk-reducing factors. So I already kind of alluded to some of these. Breastfeeding reduces the risk of sudden infant death syndrome. Having immunizations, yes, it does lower your risk of sudden infant death syndrome. And you're going to run into patients that think everything in the sun can happen, everything bad can happen with immunizations. I actually have seen patients come in and say that they read somewhere that immunizations can cause Down syndrome. I'm not kidding you. This is what you will run into. Okay, immunizations absolutely do not cause or contribute to sudden infant death syndrome. It's actually protective. So babies should be up to date on their immunizations. It can, as much as 50%, reduce the risk for sudden infant death syndrome. And then pacifier use during sleep. So you would think this is kind of counterintuitive. We don't want the baby to be around things in bed. We don't want toys or blankets or pillows in the baby's crib. But a pacifier use, if the baby does indeed use the pacifier, is okay, and it's actually supposedly reduces the risk. The reason for that, as far as I know, would probably be because the pacifier changes the position of the tongue inside the mouth, and that helps with breathing. Another thing that I've read is that using the pacifier, and I'm not exactly sure how this would work, but the pacifier would reduce the arousal threshold for the baby. So I guess theoretically, if the baby stops breathing, has a pacifier in, then the baby's more likely to wake up and start breathing again than if they don't have a pacifier. So don't worry about why. Just know that pacifier use during sleep is not only okay, but it's a good thing. All right, so this Back to Sleep campaign has been sort of modified, and it is now called a Safe to Sleep campaign. And what the Safe to Sleep campaign is it's a set of recommendations for educating parents in what to do and what not to do when putting baby to bed. So let's start out first with the things that you do. So the most important one is always place the baby on the back for sleeping. So it used to be called back to sleep, now it's called safe to sleep, but yes, you still put the baby on their back for sleeping. Not on their side, not on their tummy. Why not on their side? Well, side sleeping might be okay if they're sleeping on their side, but the problem is it's an unstable position, and if the baby rolls over, there's a 50% chance the baby's going to roll over and they'll be on their tummy, and that's a bad thing. So baby needs to be on their back. Secondly, use a firm sleep surface, removing all soft objects and loose bedding. So look at this baby. There's nothing in the crib other than baby, and that's the way it should be. So no pillows, no extra blankets, no toys, no stuffed animals, just baby in bed, nothing else. Now you can have a blanket. If you have to have a blanket, then there are guidelines. If you have a blanket, just make sure that it's tucked in nice and snug on 3 sides, and that's okay, but it's not ideal, all right? Next, keep baby in the same bedroom as parents, but not in the same bed. So sleeping in the same bed is a no-no, but sleeping in the same bedroom is a good thing. So if you should encourage that if you can. Allow the baby to sleep with a pacifier. We already talked about that. There is one exception, and that is babies who are breastfeeding during the first month of life. I have no idea why, but that is what the studies have shown. So breastfed babies during the first month of life should not have a pacifier during bed. But other than that, pacifiers are absolutely okay. And then also allow supervised tummy time. Now, this has nothing to do with sudden infant death syndrome, but it does have to do with the fact that back in 1994, when we started telling parents to put their babies on their back when they go to sleep, we saw a sharp increase in a cranial deformity known as plagiocephaly. And plagiocephaly is essentially similar to that sort of cone head that you see in babies after vaginal delivery. And you can imagine what you get when parent comes in and says, "You told me to put my baby on their back and now their head is deformed. And you told me that that would go away after the baby was born." And plagiocephaly, unfortunately, is one of the negative consequences of all of these things that we're doing with the Safe to Sleep campaign. Now, I would rather my kid have plagiocephaly than die of sudden infant death syndrome, because you can correct plagiocephaly. They use helmets and stuff like that, but you can also prevent it too. So this supervised tummy time, basically, I mean, I'm not going to talk about exactly what that is, but essentially what you're doing is you're putting the baby on their tummy while they're awake and allowing them to sort of play and maneuver around, but supervised. Okay, because if a baby falls asleep on their tummy, that's a bad thing. So as long as the baby is awake, they can be on their tummy all they want. That's fine. But what we don't want is for baby to fall asleep when they're on their tummy. And so that's why it's supervised tummy time. And this will reduce the risk of developing plagiocephaly and needing interventions to correct that. Okay, what do you not do? Share bed. Never share bed. Sharing bed is a bad idea. All right, and like I said, I've seen all this stuff come out on CNN and Yahoo News and Google News and all this stuff that circulates out there from rather non-reliable sources saying that sharing bed is okay, it's not a risk. This would contradict a lot of evidence saying that indeed there is a risk. There are these wedges or positioners that they sell that are supposed to keep, where you can divide mom or dad from baby. Not recommended. Okay, so sharing bed is not recommended at all. Don't do it. After 1 year of age, then it's probably okay. But until then, sharing bed, no. Sharing bedroom, yes. Sharing bed, no. Also, don't overclothe the child. So the way this baby is clothed is fine. So baby probably has something on underneath this, maybe like a shirt or something, some pants, but this nice little button-down onesie is good because there's really no way the baby's going to be able to asphyxiate on this, because this is all just one article of clothing. So it can't be manipulated or get over the baby's face or something like a shirt can. So, and this also helps keep the baby warm too, because you have an extra layer. So these sort of footy onesies are a good pajama for the baby. And then also, this sort of goes without saying, don't smoke during pregnancy, and then don't smoke indoors with the child. And that also extends to electronic cigarettes. So this is since we started the Back to Sleep program in 1994. So if you look back in 1994, infant back sleeping rates were roughly around 12 to 20%. Okay, so when we first started out, in 94 we started this study, and back sleeping rates went way up. Now, this only goes to 2007, but it's roughly about the same now. It leveled off around 70 to 75%. So we have about triple the number of babies now, percentage of babies sleeping on their backs as opposed to sleeping on their tummies. And if you look at the SIDS rate, it has gone down significantly. So in 1988, which would be the year that I was born in, the death rate was about 1.4 per 1,000 live births. Now, well, as of 2007, it is less than half of that. So 0.57 deaths per 1,000 live births. And you can see that this drop coincides with the back sleeping rates. So once that back sleeping rate sort of leveled off, roughly around 2002, that's right about the same time that the decrease in SIDS death rate leveled off. So there is a very clear correlation here. Now remember that I said that Black children and Native American children are at increased risk, and this is true. Now we don't really know exactly why this is. However, we do have some interesting evidence, at least on the Native American side of things. Particularly here, we're talking about Alaskan Inuits. So yes, Black children are at higher risk, and that might be because of the socioeconomic status issue. Blacks in the United States are more likely to be in poverty than are other races. However, when we're talking about Alaskan Inuits have a lower level of an enzyme called carnitine palmitoyl transferase. And that enzyme is implicated in fatty acid metabolism. And that enzyme has actually been useful evolutionarily for these people because they live in colder climates, they eat more fat in their diet as opposed to carbohydrates, and that enzyme actually allows them to metabolize fat better. And so it's actually evolutionarily advantageous for them. However, the fat metabolism issues that surround it apparently put them at a greater risk for SIDS. And this is interesting because children who have disorders of fatty acid metabolism are at risk for sudden infant death in general. And we'll see that when we get to how we differentiate. Okay, so that's sort of what's behind that Alaskan Native. So we say American Indian, but really it's particularly these Alaskan Natives that are at very high risk. Okay, so this just goes on. This is the most recent thing I could find, but I've seen some articles since then. This was in 2014 in the summer, but I've seen some articles since then putting out information, and they weren't scholarly articles, but some articles saying that, oh no, baby sleeping with mom and dad in their bed is okay. No, it is not. And even if one study said that, there's a bulk of studies saying that it is a bad thing. Right? And it just makes sense. If baby is not supposed to sleep with a pillow and a blanket in the crib, they probably shouldn't be sleeping in mom and dad's bed where there are pillows and blankets. Right? So just keep this in mind, please. Got to be really careful. The internet it's a wonderful thing, but at the same time, it's got a wealth of crappy information, and patients will latch onto that. They'll hear things by word of mouth, and they'll ask you these questions. You need to be aware that there is bad information out there, and you need to dispel myths. I'm sure by 2030, you're going to be spending half of your waking hours dispelling myths in the clinic. All right, so for diagnosis, as I mentioned, it's a diagnosis of exclusion. A full history and postmortem physical exam should be performed. You will ultimately have an autopsy. Important differentials include, but are not limited to, first, child abuse. So you're always going to get a full skeletal survey in these children. that come in having died from suspected sudden infant death syndrome. So you get skeletal studies, get toxicology studies, and that's useful for uncovering evidence of child abuse. So what do we look for? We look for rib fractures, we look for spiral fractures of the humerus. And of course, you want to look for other stigmata of child abuse, like burns that are in a pattern or cigarette butt burns, things like that. Particular findings to note also are cranial injuries, abdominal trauma. Make sure and palpate the liver. Sometimes you can get liver lacerations from being kicked or punched. And then hematomas. So you just nicely palpate the skin, look for any kind of bumps or masses anywhere. And any finding that's abnormal will warrant a further investigation with more accurate imaging. So you might get a CT in that situation. You don't have to worry about exposure to radiation because the child's already dead. Remember also that SIDS is very unlikely after 1 year of age. 1 year is the cutoff. And I suppose theoretically a SIDS-like process, asphyxiation, could happen after 1 year of age. But if you have a picture that looks like SIDS, but the baby is 12 or even 11 months old, you really should be thinking of something else. Even past 6 months of age, it's very unlikely that it's going to be SIDS. Suffocation can be deliberate or accidental, and it appears almost identical to SIDS. So the best way to differentiate out suffocation is to try to differentiate out possible intentional suffocations. So things that might point you towards intentional suffocation. That could be that there have been recurrent issues around one caregiver where the baby has gone apneic or cyanotic around that one caregiver. If a baby is more than 6 months of age, accidental suffocation is unlikely after 6 months of age, at least during sleep. Then previous sudden unexplained infant death under the same caregiver, that's a big red flag there too. And then when you're doing imaging, if you look at the lungs and you notice an old pulmonary hemorrhage, or even better, if you note it on autopsy, that is a red flag as well. All right, so it's very difficult to differentiate these out, and I don't expect if the USMLE gives you a question where it's some kind of an intentional process or child abuse, they're going to make it pretty clear. Because you really can't make it not clear on a test question. But in real life, this can be very difficult. So you just have to keep your eyes open. Inborn errors of metabolism. So this goes back to what we were talking about earlier, fatty acid metabolism disorders. So now, this is a big deal because when you think about it, you've got maybe 3 kids have died to the same family, and they've all died from sudden infant death syndrome. And you think, well, gee, these parents are either have really bad luck or they're causing this. And your brain might think, well, they must be causing this. It must be, Occam's razor here, the most obvious explanation. They're causing this. This isn't just bad luck. Well, it very well might be bad luck. There are fatty acid metabolism disorders, and they're genetic, and they can occur in the same family. And so you should consider fatty acid metabolism disorders if there's been multiple occurrences in the same family, because that's helpful for genetic counseling for later pregnancies and babies in the family in the future. I will say, though, that a lot of these inborn errors of metabolism are screened for on just the routine newborn screening. And then cardiac channelopathies, mostly here we're talking about prolonged QT syndrome. Okay. So what do? You have now a baby that has died in the ED. Just some tips as far as what your role is as a physician. So informing the family or caregiver is always going to be the responsibility of the senior-most medical staff taking care of the baby. So that's going to be the emergency practitioner or whoever's their attending physician, pediatrician. It's the responsibility of the senior-most staff. So Do not delegate this responsibility to your medical students or delegate this responsibility even to your residents. It's not okay. Certainly they should be there. It's a good learning opportunity, but this is the responsibility of the senior-most medical staff. Other things to do not do. Do not approach the parents in a confrontational manner. Yes, there may be signs that you see possibly child abuse. However, child abuse really only accounts for less than 10% of cases that are diagnosed as SIDS. So it's even if there are, even if the child does have SIDS and you get a bad vibe from the parents, you're not going to approach them in a confrontational manner. You're really never going to approach a parent in a confrontational manner ever. It's your job to stay neutral. Okay, if you suspect that this may be child abuse, then you refer the case to Child Protective Services. But don't be confrontational. Don't don't be accusatory, and definitely never say the A word around the parent. So never just bring up, well, we're looking at possible child abuse here. No, you don't do that. That is the job for Child Protective Services. So certainly it's okay to say, Child Protective Services is going to be involved. We have this or that possible evidence, but we don't know, and this is just part of standard procedure. That's okay. But to just come out and say, well, we think this possibly is abuse. Remember, you're dealing with parents that are distraught. And the last thing you want to do is add on more stress to them. Okay, so that can all be dealt with in due time. And certainly, if you suspect abuse, you will have Child Protective Services in there immediately. But it is not your role to be confrontational. Let Child Protective Services do their thing. You do yours, and try to just keep them separate as much as you can. All right. What do? You inform the parents in a private room. All right, nobody likes to be told bad news in front of a bunch of other people, so it's always okay. Even if it means not necessarily in a private room, although they usually are available, but if it's off to the side, okay, allow the parents room to mourn. This is any time that you're informing parents of their children's death. It really presents an emotional, a cultural, a procedural, a legal challenge. And so you really need to be careful here. You should provide the likely diagnosis that we believe this is, we're working on the working diagnosis is that this is sudden infant death syndrome, but we're going to perform further investigation, and you can tell them what you're going to do. Like, you're going to review the history. You're going to, and this typically will need to be done. You're going to look, somebody will usually go to the home and look at where the baby died, to see if there was anything around there. There are various things that these forensic pathologists can look for. It can be like if there are any items around that maybe the parent didn't notice, or blood-tinged sputum or secretions can possibly point towards there might have been some obstruction in the respiratory tract. There's various things that these pathologists can look for there. And then, of course, also a formal autopsy. So those are things that you can tell the parent is going to be done, provide them with a likely diagnosis and sort of what you're working with. But other than that, you really want to give these parents as much laterality as possible, since they are grieving. And this is one of the most traumatic things that a person can go through in life, is losing a child. So permit and encourage the parent to spend time with the child or hold the child after death. That is absolutely okay, right? Usually, and it has been recommended by, I believe, the American Academy of Pediatrics Committee on Child Abuse, as well as the National Association of Medical Examiners, which I think is just, sort of like the coroners union. They've recommended that a neutral person, like a staff member, be present in the room while the child, or while the parent is with, the body. But that's not absolutely necessary. And then also refer the following services if available. So pastoral care. Most hospitals will have pastoral care. That's something that you should offer if it's desired. Grief counseling, funeral arrangements, and then there's, because SIDS is relatively common, there are support networks that are available for helping these parents cope, finding other parents that can relate to what they're going through, and that can be helpful for them. So ultimately, this is not something we treat because it's death syndrome. So these children come in dead, so there's nothing we can do about it after the fact. But what we can do and what we need to continue to do is prevention and education. So while the Safe to Sleep program has been highly successful, competence among healthcare providers is subpar, and I am putting that in the nicest terms possible. So when I was reading through some of these statistics, I was actually aghast. So hospital surveys show that about 90% of nurseries are using the side sleeping position as an acceptable practice, when we know darn well what happens when you're sleeping on your side. You're probably going to move to either the prone position or to the supine position, and it's probably like a flip of a coin. So that is absolutely not an acceptable process. And the fact that 90% of nurseries, 90%, are unaware that the side position is not acceptable, that's pretty astounding. 42 to 60% of nurses identified themselves, so this is self-identification, as always following SIDS prevention recommendations when preparing infants for discharge. So that's good. I mean, that there are some that are following it, but that's still not that much, 42 to 60%. So think of all those other nurses that say they're not always following the SIDS prevention recommendations. And this does not just fall on nurses, although nurses play an invaluable role in educating parents about preventative measures for SIDS. This also goes to doctors too. So when you have mom and dad with baby come in for 6-month well child visit or 2-month well child visit or what have you. Sorry, my dog is going nuts upstairs. But anyhow, when parents come in, this is another opportunity for you to educate them on how they should be putting their baby to bed, what should be in the crib, what shouldn't be in the crib, use pacifier, dispel myths, etc. And actually, while almost all clinicians, and I think primarily here we're talking about physicians, admit that they know the importance of SIDS education, only 30% or 30% report not discussing it with their patients at all. And I would be horrified to know how many of these clinicians just refer to it in passing rather than giving a good comprehensive refresher on safe procedure. So you put all this together, it's no wonder that we're not seeing the continued improvement that we saw in the 1990s. And so what this all boils down to is that it is our responsibility as physicians, as nurses, as PAs, as healthcare professionals in general, it's our responsibility to educate the parents and to provide a quality education, something they can remember. And a good way to do that, even if you're not, let's just say, you're not very good at teaching patients things, and whatever, it's good to know your weaknesses. But there are other things you can do. You send the parents home with a brochure, something, but at least make sure that they get out of there learning something about SIDS prevention, especially you're talking sending them home from the hospital after baby's born, at the 1-month visit, at the 2-month visit, at the 4-month visit, and even at the 6-month visit. Important that you continue to refresh them. And SIDS education should continue at all infant healthcare visits up until the age of 1 year. So here's just some a picture showing good practice. So baby is sleeping in a crib. Baby is sleeping on back. Nothing is in the sleeping area. Baby's face is uncovered. No smoking around the baby. Don't overheat or overdress. You'd rather the baby be a bit cold than the baby be overheated. It doesn't take much to overheat the baby, then raise the risk for SIDS. If the baby is a little chilly, they'll probably get by with it. Okay, it's really hard to overdo it in the other direction unless you're really trying. And then a firm mattress with a tight fitting sheet. It should always be a fitted sheet. Don't just drape a blanket over the crib. And then this is something that, something very basic you can send home with the parent. Okay, so just, if you work in a pediatric office, print this out, send this home with parents of any child between the age of 1 month and, birth and 1 year. So this is very simple. You can remember this. ABCs of safe sleep. So alone, meaning no bed sharing, not with other people, no pillows, no blankets, no stuffed animals in bed. Certainly fine to have stuffed animals and blankets when baby's out crawling around and awake, but none of that stuff in bed. B, on my back, probably the most important factor of all of these. Baby needs to be on their back in the supine position, not on the stomach and not on the side. And C, in my crib, not in an adult bed, not on a sofa or a cushion or other soft surface. Now, it very well might be that baby falls asleep on the floor, or baby falls asleep on the sofa, or baby falls asleep in their car seat or in the stroller, and that's all fine and good. Just make sure that the baby is then placed in their crib in a safe place after they've fallen asleep, or just wake them up. You can do that too. Um, but baby should definitely be sleeping in the crib. All right, so if you have any questions, go ahead and let me know. If there's anything else that I should have addressed, let me know. This is mostly, you probably gathered that this wasn't so much about the test as much as it's about learning how to educate your patients and how to approach them in a clinical setting, especially in very sensitive clinical settings. And these are some very important things that you can learn and take with you for practice. I will see you in the next section.